Hi, my name is Judy Nee. I'm a physician at Beth Israel Deaconess Medical Center here in Boston, Massachusetts. I'm the director of the Center for Irritable Bowel Syndrome and GI Motility here in Boston. One of the first things that we talk about in clinic when patients have chronic symptoms of abdominal pain, diarrhea, constipation, is that you can have a disorder of brain-gut interaction. And these are diagnosed as functional bowel disorders. These are incredibly common. 1 in every 4 adults in the US, Canada, and the UK has actually had one of these 6 very common functional bowel disorders. You can see here on the pie chart that you can have very commonly irritable bowel syndrome. That's the most common thing that I see: abdominal pain with a change to the bowel movements, but without any alarm symptoms. So no blood in the stool, nighttime symptoms like diarrhea at night, weight loss, or family history of Crohn's disease or ulcerative colitis, or what is known as inflammatory bowel disease. But why is this important in women? Women are twice as likely to have irritable bowel syndrome. There are a lot of reasons why this may happen. One of the things is that a lot of the chronic pain issues that coincide with irritable bowel syndrome are much more common in women. We don't know why, but fibromyalgia, chronic fatigue, chronic pelvic pain, chronic pelvic dysfunction, and migraines are just more common in women compared to men. The other thing that I'll talk about in a minute is actually about hormones and the fluctuation of hormones in women and females with those hormones that change with menstruation, but also with changes in life. So at the time of menopause and afterwards. The other common thing that I'm going to talk about is actually endometriosis that actually coincides often with irritable bowel syndrome. It's actually not talked about a lot, but infections are very common in the GI tract. It is thought to occur in over 10,000 people per year. So 1 in 6 individuals in the US will actually have a risk for an infectious event in their GI tract. And afterwards, women are 2 times more likely to have irritable bowel syndrome after that infection. So those chronic GI symptoms that seem to linger for a while afterwards, compared to men who are less likely to have that occurrence. I'm going to talk about this idea of menstruation and how it changes your GI symptoms. So a lot of women say, well, it's really common for me prior to my period to actually have abdominal discomfort, bloating, and then during the period, and then afterwards potentially get better. And this is actually natural. The variation that you can see here in the hormones, and this is a very complicated chart to basically say we have fluctuations of estrogen, of our progesterone, and that can alter our GI symptoms. We've actually done studies where they actually follow people who have been diagnosed with irritable bowel syndrome and those healthy women who don't have any GI symptoms. And when they actually report the same symptoms. The severity is just different. So actually, you get more abdominal pain, more bloating, specifically before the period. People tend to get more constipated, but obviously there are caveats to that. Some people do not. And then during the period, you seem to have more diarrhea, a little bit lessening of that abdominal pain, lessening of the bloating, because of the changes to menstruation. It can be heightened again because you have irritable bowel syndrome. So it's something to consider. What is normal is that, yes, there are some variations, but if it severely impacts your life, then it's something to talk to the gastroenterologist about to your primary care doctor about how that's affecting you, the GI symptoms surrounding the period. What do we know about menopause and GI symptoms? So along with hot flashes, night sweats, sleep problems, mood changes, vaginal dryness, there's actually changes to our GI tract. And there's not a lot known about this area. Some studies say to us that actually your GI symptoms could get worse as menopause occurs, more constipation, more diarrhea, potentially more abdominal pain. But there are other studies that show it actually improves with time. So it's unclear exactly how menopause would affect the GI symptoms, but it's just important to note that some of these symptoms may be due to those changes to the hormones. And again, if you have these symptoms and the change of life is happening where you are missing some periods, feeling some GI symptoms, some of that may change over time as the final last period occurs for someone like yourself. The next thing I'm going to talk about is actually endometriosis, which is thought to be about prevalent in about 10% of the female population. What does it mean? It means that you have endometrial tissue that usually is in the uterus, but found elsewhere. So it could be found in the GI tract, it could be found in the abdominal cavity, it could be found in the bladder. So there can be any location where this endometrial implant has occurred. Why is this important in the GI world? It's because many of these people who have endometriosis actually have symptoms of irritable bowel syndrome. So those same symptoms of abdominal pain, change to the bowels, difficulty with defecation, pain with defecation, all of those are actually very common symptoms of IBS. But then the same people who have endometriosis actually are being diagnosed with IBS. Again, why is this different and why would it make a difference for you? It's that if you're having symptoms, it would be important to talk to your GI doctor about not just the GI symptoms. What other GI symptoms? So, uh, there can be pain with intercourse, so painful periods, irregular periods, heavy periods. In terms of the urinary tract, you can have actually pain with urination as well. So, all of this interacts, the GI tract interacts with the bladder as well as the uterus, and then also with that hormonal fluctuation. And so it's something to consider. It's something also that GIs are very reluctant to talk about, but it's something that significantly affects treatment. If you are diagnosed with endometriosis, which is typically with the help of our gynecologists to talk about the symptoms and then also the treatment, it can significantly help the IBS symptoms that have nothing to do with GI medication, right? It can actually be hormonal treatment, whether that's with injections or with oral contraception, or sometimes in more severe cases, sometimes surgery. The last thing that I wanted to talk about is actually the pelvic floor. The pelvic floor is incredibly important in women. It can be altered with all the changes of life that I've talked about, including fluctuations in your hormones, including having giving birth, including surgeries like hysterectomy or oophorectomy that patients can have. But the pelvic floor is this trampoline that holds the bladder, it holds the uterus, and then it holds the rectum. And all of that has to interact together to actually have a successful bowel movement. And what I mean by that is that you may have symptoms of incontinence, fecal incontinence, for example. So a stool comes out without control. If you have the urge, but you can't actually hold the bowels in, those are all reasons to talk to your doctor. Hey, this isn't just normal aging. This is actually the interaction of all of those organs in and the pelvic floor. So, what I was going to describe today is actually how the normal occurrence of having a bowel movement occurs. Usually, you sit on the toilet, you get the urge to have a bowel movement, you sit on the toilet, and you actually bear down with your belly. And what happens is the anal sphincter should actually relax. And I always give the example of getting toothpaste out of a tube. If you want to get the toothpaste out, this is the tube. You want to press the tube and then you uncap the tube, right? If you left that cap on and you press, nothing's going to come out. And this is what can happen. It's called pelvic floor dysfunction or dyssynergia. It's very common in women, more common in women, but it is still unclear exactly why it happens more in women. But what's happening is that anal sphincter can potentially not relax, or even tighten up, and you may not have great push bear down, pushing down the rectum so that there's just no forward flow, meaning flow out of the anus into the toilet bowl. What do we do about this? And why does it matter? It's that if you have constipation, fecal incontinence, we have testing for this. The main test is anal rectal manometry, which is a catheter that gets inserted into the rectum, and you do a series of maneuvers. And then, if we diagnose that you have dyssynergia or pelvic floor dysfunction, you can actually get biofeedback. This is physical therapy for that pelvic floor. So what that means is that somebody working as a physical therapist would be working with the patient and working with you to actually go through a series of sessions where either their finger or a probe is in the anal sphincter, and you could actually figure out the dynamics of that bowel movement. So relaxing that anal sphincter appropriately and giving that bear down. Um, People often ask me, "How often do I have to go? What is this?" Right? And it is an incredibly invasive physical therapy, but it is incredibly effective. So in studies, 70% of people actually improve their bowel movements, whether that means a decrease in fecal incontinence, improvement in their ability to have a bowel movement, their ability to decrease their laxatives, or potentially to get off the laxatives. For a woman, for females that have that pelvic floor, those muscles need to be strengthened and coordinated, just like your biceps or your thigh, right? That you have to exercise that pelvic floor, and in a way that is counseled by someone as opposed to just thinking yourself or exercising yourself in some random way to actually have appropriate bowel movements or less fecal incontinence. A lot of people do ask me then, is there a surgical alternative for this? Or what are other things you can do for dyssynergic defecation or this dynamic that's a little bit off? Surgery is not a great option, but there are pelvic floor abnormalities like rectoceles, intussusception, um, all kinds of abnormalities that can be seen in the pelvic floor that are potentially not affecting the symptoms. So what that means is that sometimes we can do imaging. For example, there are MRIs or images that we can take of the pelvic floor that can give us so much detail about what's going on. But in the end, those are potentially the findings, true, and unrelated. That you can find, you have a rectocele, which is just an outpouching that occurs in the rectum. And that's actually not worsening the symptoms in any way or contributing to the symptoms. So it is worth talking to a gastroenterologist just about the whole picture and the dynamics of how the person has a bowel movement, as well as potentially imaging to see what physically is there, and then discuss with the gastroenterologist as well as the surgeon potentially what could be done. Thank you so much.